of 7th of February, and I'm very happy to collaborate with the team to discuss about a new technology, or rather, which is a new technology in the sense that it is still not so easily available to many patients all across the world. And this is actually non-surgical aortic valve replacement. It is actually not a replacement, it is an implantation, and we all know that for doing the valve, you have to open the chest. In this condition, where we are talking, what we are talking about is a non-surgical method by which we can always talk about the treatment modality without opening the chest, as we are doing for angioplasty and stenting. This was always a difficult task, and this was actually started with my mentor, Professor Alan Crevier, who is now known as father of TAVI. And he started this process when I was privileged to be working with him in 1996, 97, 98. That means almost 53 years back, when he had thought, and when he was driving a car and I was sitting with him, he said, "Vivek, I have an idea." I mean, what is that? He said, "I have an idea to put the valve without opening the chest." I was totally, I was so confused how it is possible. Then finally, after a lot of animal experimentations, 2002 was the year when it was started. The first case was done by him. So I'll now share the slide to discuss more about details, and I give my big regards to the father of TAVI, Professor Alan Crevier, who started this process, and now today more than 5 lakhs procedures have been done worldwide. Although in India we do not have so many number of cases, but worldwide so many cases have been benefited, and this is actually a life-saving therapy. And I will show you the first case which we did from India in France. Also, we'll discuss about that. So I'll go a little slow because this is actually a webinar where a lot of physicians will also be listening later on, not only cardiologists. So I'll be talking something which is easily understandable not only to cardiologists but also to the physicians and also to the public at large, because finally the patient is mostly public and they have to understand in a simple and easy language. So I'm going to start my screen with this. So I think the screen is being shared very well.
Yes, doctor, your screen is visible.
Okay, so I'm on the left side, so I'll put my photograph on the left side, rather, it can go anywhere, but it doesn't matter. So finally, what we're talking is transcatheter aortic valve implantation, and I'm talking from bedside to bedside. Bedside means where it was actually, the idea was conceptualized, and that was 1996, 97, 98. And how the first case was done by Professor Alan Crevier. And that's why I showed this on the left side, a beautiful picture of Rouen. Rouen is a place which is Normandy, which is a very beautiful city of France. It is 130 kilometers from Paris. When you go from Paris towards the English Channel, that means you go towards England, you will cross this beautiful city. And this is actually a cathedral, and somewhere nearby is the hospital Charles Nicolle, where I was working with our Professor Alan Crevier. And since, why I'm talking about him again and again, because not only is a very fantastic person, but also he's a father of so many things. He has done a lot of innovations. And here you can see the picture of Indraprasth Apollo Hospital, where I'm working presently since 1998, after coming back from France. So this is a beautiful city, and I still adore, and I really have nostalgic thought process about this place where I worked, and immediately after doing my DM, I went to France. So what is the plan of presentation? The scope of problem of degenerative aortic stenosis. I will talk about degenerative aortic stenosis, and then I will talk about balloon aortic valvoplasty. Then I will talk about development of non-surgical aortic valve and the first in-man plantation. And this will take a long time because I will talk about details about the non-surgical aortic valve. And then we'll go step by step how the case report. I'll show the case report which we did in November 2011. And most probably this was the first case from India ever treated by TAVI. Although we could not do it in Apollo, we had to take this patient to France because at that time Edward valve was not yet approved by DCGI, which is Drug Control Government of India. And what are the current indications? So let us talk about the aortic valve. So what is the scope of problem of aortic valve stenosis? Degenerative aortic valve stenosis, let me talk about for the public also that there are 4 valves inside the heart. And if I'm visible here, I can show you this picture of the heart where you can see that I can open the heart and you can see that there are valves. This is aorta, there's the aortic valve just here, then this is a pulmonary artery, there's a pulmonary valve, and then you can see the right and the left chamber which is opened up, and this is the tricuspid and the mitral valve. So the two most commonly diseased valve which require intervention is mitral valve, which we're not talking today, and then the aortic valve. Why aortic valve is so important? Because you see this is the aorta which is giving the blood to the whole of the body. And when the valve which is diseased, which is supplying the blood, what is the purpose of the heart? The purpose of the heart is to contract and supply the blood to the whole of the body. And when this valve gets diseased or stenosed, then the supply to the whole body will be affected. First of all, the supply will be affected little late, but there will be problem with the ventricle because the ventricle is now contracting against the stenosed valve and the ventricle is likely to fail. Secondly, the pressure inside the ventricle will go up and the patient will go into pulmonary edema, patient will have syncope, and the patient will have coronary the angina. So these are 3-4 symptoms of aortic valve stenosis, and aortic valve stenosis is getting more and more common. What we are talking about is degenerative, not the rheumatic, degenerative aortic valve stenosis, which means with the aging process, the patient aortic valve gets stenosed and leading to the problems, and this can also lead to sudden death. One of the important cause of sudden death is also severe aortic valve stenosis because of cardiac arrhythmias, and patient does not know. You must have seen that, must have realized that a lot of patients, they have sudden death, and one of the important causes is myocardial infarction. The second most important cause is degenerative aortic valve. So this is the most common acquired valvular heart disease in adults. 26% of the population above the age of 65. 26% of the population of the age of 65 has mild, moderate or severe aortic stenosis. 2% are symptomatic and should require treatment. It is estimated that within 15 years, the number of aortic stenosis patients will nearly double. So it's a significant number of patients who are getting affected, not only in India or not only in Europe, but also in India. In Europe and America, it's getting more and it's more common because they have a higher population which is above 65 as compared to India. Now the aging, the process, the lifespan of the Indian population because of the increased healthcare system is also going up. So when the patient is living beyond 70, is likely to have 26% of the population above the 65 will have mild, moderate or severe, and out of this at least 2% are symptomatic and should require treatment. So valvular aortic stenosis in adult, overall symptom, once the patient has symptoms, this is very important. Once symptom develops, symptom means angina, syncope or heart failure, the average survival is only 2 to 4 years. Once the symptom develop, the average survival is not more than 2 to 4 years. That means we have to do something which can change the lifespan. You have to change the valve, otherwise the patient is going to die. Something like heart failure, something like cancer, because the survival with a cancer patient, carcinoma patient anywhere with the early metastasis, they don't survive beyond 2 to 4 years. So it's like a cancer of the heart. I would not say it is carcinoma because the survival is so poor unless you have the treatment. Surgical intervention should be performed promptly once the minor symptom occur. When the patient symptom, you have to change the valve with the surgery, and this is a very important point. You have to understand that aortic valve stenosis severe has to be changed, otherwise the patient is not going to live more than 2 years. In elderly population, the prognosis is even worse. 30% death within 3 months in patient waiting list for TAVI. That means that the patient is elderly beyond 80 years, the survival is not more than 3 months. It's very scary. It's very scary. The patient will not survive more than 3 months if you have patients beyond 80 years having a severe aortic valve stenosis. In most of the patients, what we have been doing earlier, in any patients, we have to do a surgical valve replacement. That is known as aortic valve replacement, AVR. This is standard of care. Mortality, the mortality after AVR is low, 2 to 5%. But with increasing age, this is important slide again. With increasing age, poor heart functions, bypass surgery requiring, or comorbidity of kidney failure or lung disease, the morbidity is high and mortality is high, and lot of surgeons would not like to operate such patients. That means most of the time the surgeon will say no. But at the same time, after successful valve replacement, patient lifespan returns to that of general population. This is very important. You change the valve either by non-surgically, by TAVI, or by surgically, by aortic valve replacement, the patient lifespan returns to normal as a general population. But before TAVI came up here, we should talk about balloon aortic valvoplasty, which is opening the valve with the help of balloon. And this was actually first done by Professor Alan Crebier again in the year 1985. It was published in Lancet Journal 1986, and at that time, the age per se was a surgical contraindication. That means the patients were not allowed to be operated because of high risk. Patients were not getting operated, and therefore Dr. Crebier found the idea of putting a balloon across the valve. This is the long balloon across the valve, inflating the balloon, and of course the stenosis disappeared. This was the first case to a 72-year-old woman, highly symptomatic. She had a daily syncope, angina, and she was declined by the surgeon. And this was the first case where it was published. It was published in Lancet in January 11, 1986. A memorable reaction to the medical community, and the patient survived for 2 years. This was a very important landmark because for a long time I would like to explain to the patient why this was important. When you open the mitral valve, you're not occluding the supply to the whole of the body. But when you're putting the balloon inside the aortic valve, for that particular time, the whole of the blood supply to the body, when you put a balloon across this valve, when you put a balloon here like this, as you can see here, the whole supply to the whole body is finished, stopped for the moment. So you have to be very, very quick. At the same time, you should not disturb or harm the valve so that it leads to severe regurgitation or the backflow. So that is why a lot of people, doctor and cardiologists, were very much afraid of doing this. It was Alan Crebier who did for the first time in the same hospital I showed you in Rouen in France, which is 130 kilometers from Paris. And this was a very important landmark. And the balloon was named as Crebier-Latac balloon. Crebier is the name, and Latac means Crebier was working as a professor, while Latac was the head of department of cardiology in the same hospital. It was developed by Mansfield and Boston Scientific. But at the same time, it was realized that the longevity of balloon aortic valvoplasty was not long. There was a recurrence, and the patient did not have the aortic stenosis came back, and there was a restenosis phenomena, and therefore it was not considered as a long-term procedure in 1980s. Thousands of cases were performed worldwide, impressive number of registries, hemodynamic symptomatic improvement, and less rehospitalization, FDA approval in restricted FDA indications. But however, the limitation I told you, early valvular restenosis and no beneficial effect on the long-term mortality. So this was the limitation. So at that time, solving these issues became a personal obsession for Professor Alan Crebier, who developed the valvoplasty. But then he said, if it is no beneficial effect on long-term mortality, and also there is early valvular restenosis, that means there is a recurrence in the valve stenosis, then he thought of developing transcatheter heart valve. And in 2015, the balloon aortic valvoplasty became a simpler and safer technique. And in all patients of TAVI, you're required to do a balloon aortic valvoplasty at the time when you have a rapid ventricular pacing and balloon size 20, 23, 25, smaller sheath size per close technique, and 3 days of hospitalization. Coming to the important part, that non-surgical aortic valve and first in man implantation. So I personally feel I would not like to talk about this now, that Rouen, since 1990, there was an innovative technology in the field of valvular disease, and in 1985, balloon aortic valvoplasty till 2002, when the first valve was implanted, there was a lot of work done. And this was a huge leap actually, and that is why it's important to know about this. In between, Dr. Crebier also developed 1997 mitral commercial stroke. Mitral stenosis is a disease of developing countries like India or Southeast Asia, because we have more patients of rheumatic heart disease, and this was developed by Dr. Crebier in 1997, which was actually a metallic mitral commissurome which can be reused again and again. So what Dr. Crebier believed was, Edwin Land, don't undertake a project unless it is manifestly important and nearly impossible. Don't undertake a project unless it is manifestly important. It has to be important and nearly impossible. This was what Edwin Land spoke sometimes back. So developing TAVI are unrealistic project, Implanting a valve prosthesis within the diseased calcific aortic valve on the beating heart using non-surgical percutaneous catheter-based technique. This was actually a project which he took in 90s, and goal was to improve the results of balloon aortic valvoplasty, and there should not be restenosis. This was the goal. It was highly challenging. Why? Because the valve is having calcification. The surrounding structures, coronary arteries, mitral valve and IV septum. As I showed you that when you see this, the valve which is coming from here, this is surrounded by a coronary artery which is coming from here, and then of course the mitral valve on the left side, and of course the IV septum, which is his bundle, which can lead to disturbance in the rhythm of the heart. That's why it was highly challenging. You can see the valve from the top. It cut open the tricuspid valve, 1, 2, 3 leaflets, highly calcific valve, hardly any opening here. And this was. Major clinical issues were coronary occlusion, mitral valve injury, coronary occlusion. If you occlude the coronary artery, patient will die on the table. Mitral valve injury can be problematic because it may require mitral valve replacement, which is another valve. It can lead to AV block, which will require pacemaker. It can lead to stroke because sometimes the calcium that goes into the carotid artery and then it goes into the cerebral circulation, can lead to stroke. It can lead to aortic regurgitation. It can lead to prosthesis migration. And of course, the result may not be so good. So these were the clinical issues which had to be discussed and found out by doing so many things. Birth of the concept of stented valve in AS. Usual observation during balloon aortic valvoplasty was any calcified valve can be circularly opened by high pressure balloon inflation. Any valve which is calcified can be circularly opened by high pressure. A balloon expandable stent with high radial force might keep the valve open. A balloon expandable stent. What is stent? Stent, we know the coronary stent. A balloon expandable stent with a high radial force might keep the valve open. A valvular structure would have to be attached within the stent. A valvular structure have to be attached within the stent. You have to have first of all balloon, then you have to have a stent, and the valve has to be attached to the stent. A challenging combination of balloon expandable frame and the valve structure. Balloon expandable frame, which is a stent, and the valve structure have to be combined together if you want to do a non-surgical putting the valve in the aortic artery. Project 1994 to 99, this was a huge problematic period for Dr. Krieger. He had an idea, he had a thought process, but he was looking for a sponsor. Search for a sponsor. Project was because unless you have a sponsorship, you can't develop a valve. A doctor cannot develop a valve unless it is supported by any company which will sponsor it. Project was submitted to all biomedical companies, including Medtronic and Edward. Let me tell you, Medtronic is a number and Edwards are number 1 and number 2 seller selling this device. And at that time when the project was submitted, 1994 to 99, what the experts said, technically impossible. The same experts who are selling it left and right today, technically impossible, clinically dangerous, irrelevant. Clinically dangerous, irrelevant. The most crazy project ever submitted. Forget it. So this was the response from the leading valve companies which were developing the valve at that time for the surgical replacement. They said, forget this, it's a crazy project and don't ever talk about it. Then after a lot of thought process, Dr. Krieger himself, along with the experts of the USA, they developed a company by the name of PVT, Percutaneous Valve Technologies. And PVT, along, this is Dr. Alan Krieger, you can see a smiling face, A. Krieger, and this is Martin Leon. So these two people, they collaborated. Martin Leon from USA, from New York, and Dr. Krieger, they collaborated with the company coming up by the name PVT, New Jersey, USA, and extensive laboratory testing was done. Animal programs, sheep model. The sheep model was used. Acute and chronic studies were done with the animal model and finalized the device, tri-leaflet bovine pericardial valve, stainless steel stent. So this was how it was developed by tri-leaflet bovine pericardial valve. The pericardium was used to develop the valve and pericardium of bovine and stainless steel stent, and this was a sort of a artificial valve which was developed with the help of technology coming from PVT in 1999. And after a lot of experiments which were conducted on the sheep in animal program, and that was the important day when the first in-man implantation of the valve was done, April 16, 2002, from Rouen, where I worked for 2 years, and this was known as first in-man implantation of aortic valve. And this is a patient who was a 57-year-old, not very long, not very old. He was in cardiogenic shock. He had multiple comorbidities. He had already had a bypass surgery done. He was sick. He had a severe aortic stenosis. And the first case, you can see the photograph of Alan Cribier on the right. Christophe Tron, he was my colleague when I was working with him in France. He was working there as associate. And Ellen Elsharinov, she's a Russian doctor working with Alan Cribier for a long time. Now she's also still there as a professor and head of cardiology, while Professor Alan Cribier is emeritus professor and doing the training program as of now today. So this was a patient. You can see the valve. If cardiologists will understand that the gradient decreased immediately after putting the valve, and this is the valve which was put. And this is 30 minutes post-implantation. Patient is smiling in the cardiac catheterization lab, and this is 8 days post-implantation. Patient was kept for 8 days, and the patient was later discharged. Lessons from this first in-man implantation. That means TAVI, transcatheter aortic valve implantation, is feasible. No embolization, no coronary occlusion, no mitral regurgitation, no pacemaker requirement, no aortic valve, aortic regurgitation. Valve had a good functioning, and immediately patient improved with a clinical and hemodynamic improvement. This is a good photograph, as you can see, and this was a bomb effect in the medical community. This was published, the first human case, published in our very important journal, Circulation. Percutaneous transcatheter implantation of the aortic valve process for calcific aortic stenosis. Alan Cribier is the first, and Ellen Elsharinov, and then many other people. 2002, I was working in Delhi, otherwise I would have been a part of this program as well. And then you can see this is it was cited in 700 articles. 3,700 articles. So this is another patient, 83-year-old lady. Then of course the patient is now completely all right, 6 months post-TAVR. So 1 year post-TAVR, TCT meeting 2004, this lady was celebrated. These are the few pictures. Alan Cribier, as you can see, as smart as possible. I'll show you some pictures of myself with him after this presentation. This is how she's working 2 years post-valve implantation. She's beating the drum. No heart failure, normal life. This is 6.5 years post-transplantation, post-aortic valve implantation. 83-year-old lady. This is a beautiful picture of one of the rooms of Charles Nicole Hospital where I was working. So this is how this study was done, and the first case, and then we go on to the clinical studies. I'll tell you more of theoretical part now. From 2002, when the first case was done, till 2002 to 2005, there were 40 patients I revived and I recast, and the patients were actually having, this was compassionate use, imminent death. Patients who were actually very sick were only taken for this study planning because this was early stages, and transseptal approach was used, and later on it was changed to retrograde transfemoral approach. This is technical part, and challenge was demonstrating the potential benefit of a disruptive technology on a subset of critically ill patients with life-threatening comorbidities. Just to tell you a little about details, this is a valve. You have a crimping device where you have to crimp the valve over onto the balloon. The balloon which is used is this. So first of all, you have to crimp the device on the balloon. 24 French sheet was used at that time. Now it is 14 French as of today. And this was done from the femoral vein. As you can see, this is the groin of the patient. Groin means jang, from where. And at that time, equine pericardium was used, and single size was available, 23 millimeter, and with no symptoms. And this was how the valve was looking into the fluoroscopy. This is a valve which was actually equine pericardium with a stainless steel stent. Sorry, these are some repeat of the slides. 2004 onwards, Edwards Life Sciences acquired PBT. This is very important history. The company which had rejected the idea now buys the same company which developed the idea. The company which rejected the idea, they said they will not sponsor it. They buy completely the PVT, and TAVI enters a new era. From Krieger-Edwards valve, which was known as Edwards-Sapien valve, 23 mm size, equine pericardium was changed to treated bovine pericardium, and then there's some change in technology. So Krieger-Edwards valve was changed to Edwards-Sapien valve. The transfemoral was changed to, also there were transfemoral, some transapical cases were done, and this is how you can see a beautiful picture of the valve which is being kept inside the balloon expandable valve, and the valve is just at the aortic valve, and you disrupt the initial valve. Don't take out the initial valve, but you put another valve. 2005, 2009 and 2012 Sapien 3 valve developed with a smaller sheath size and easy implantation, and patient was to be discharged within 2 to 3 days. And mostly it is done in the local anesthesia. So this was the minimalist approach, improving the patient life, pioneering of first since 2010, local anesthesia, no sedation, only sedation on demand. If the patient is very anxious, they will give some sedation, no transesophageal echocardiogram, and only transvagal closure devices. Procedure time not more than half an hour, very important, not more than half an hour, and patient discharged within 2 to 3 days and back home. 92% of all TAVI cases in Rouen where they were discharged. This is the cath lab, Christophe Tron and Hélène Elchaninov, doctor from France. So registries were done, initial registries were in Rouen, then of course the FIM, and then iRevive, Recast, Traverse, so many partner trials, randomized trials, and then inoperable high-risk intermediate patients. So partner 1 and 2 and 3, I'll discuss these 3 trials, very important, and which was started in USA, and how they have been able to do it, I will tell you a little while later. So randomized trial were there, multiple, many national and international feasibility and follow-up registries, pivotal trial, Medtronic core valve, and then Medtronic also started developing the valve, which is different from Edwards valve. This is a self-expanding valve, while that is balloon expandable valve. So this was initially proven by partner 1B that TAVI is superior to medical treatment. When you're developing a new technology, you have to show its superiority and safety. So this was a partner trial which showed in 2011, published in NEJM, New England Journal of Medicine, that TAVI is superior to the medical treatment in inoperable patients. That means only in the patients which cannot be operated. Then of course TAVI is equal or superior to surgery in high-risk patients. This was also proved in partner 1A trial that TAVI is equal or superior to surgery in high-risk patients. And TAVI at surgery at 5, no alarm at 5 years, and these were partner 1A and partner 1B trial success. Partner 3 was important because partner 3 showed the importance in the less risky patients, and they also showed that even in less risky patients, non-inferiority of TAVI versus SVR at 2 years in low-risk patients. You see, when it was being developed, it was only the patients who were refused by the surgeon. Now we have to develop this technology into the patients who are actually low risk. That means even surgery can be done, but the patient doesn't want to open his chest. If it is easier, for example, like angioplasty and stenting for the coronary artery disease, simpler, easier, no cut, no opening of the chest, any patient would like to do this. Non-inferiority of TAVI versus surgical valve replacement at 2 years in low-risk patients. So this was actually published and ACC, American College of Cardiology, in 2019. FDA approved TAVI for low-risk patients. This is very important. This was actually a landmark because FDA had approved this for the low-risk patients. Final surgical risk category to be approved by TAVI. So non-inferiority approved, Euroscore, TAVI in the future, TAVI might become the default therapy for a vast majority of aortic stenosis patients. The procedural advantage of TAVI clearly overweight its potential limitations. It's done in local anesthesia, no cut on the chest, no scar, early discharge, less mortality, less strokes, less atrial fibrillation, less kidney problem, and so it's much safer than the surgical. No alarm so far on the durability because now we have results beyond 5 years. That means a patient who gets it done at the age of 65, he will be at least 5 years data, and 7 years data is now available. And I will show you a case which has more than 8 years data, which is there. So these are the trials which I'm not going to details. So In younger aged patients, less than 70, in the absence of anatomical contraindication to TAVI, a well-informed patient, whatever his age, refusing surgery might have been the next future to deliberate choice of undergoing transfemoral TAVI. That means that the patient is even less than 70 and he does not want to get it operated by surgery. He can be given the choice of transcatheter aortic valve implantation. But of course, keep in mind that surgical valve replacement remains an option in case of unsatisfactory acute results or valve failure on follow-up. This is very important. Suppose the patient feels and there is something wrong happening. The patient can still be operated by opening the chest. So TAVI in the younger patients, this is something like difficult I told you. So expanding the clinical indications, bioprosthetic heart failure, bicuspid valves, severe asymptomatic stenosis, moderate AS with heart failure. So these are different subcategories where TAVI will come, and partially it has already come. For example, in bioprosthetic heart failure, that means the patient who already had a valve deployed by surgery and these valve fail, then can you put a valve in valve? This is a registry which has proven that you can put a valve in already patient who has been operated earlier. For example, bicuspid valve, severe asymptomatic stenosis, that the patient does not have symptoms. Moderate AS but heart failure, high risk aortic leak, regurgitation, aortic stenosis with CAD, with mitral regurgitation, with aortic leak, low flow, low gradient. So these are different categories where the TAVI has shown the improvement. Expansion and future of TAVI, surgical valve replacement indicated. It is a very important slide. I want to highlight this. In 2002, when it was first done, TAVI is conceived for patients who are not optimal candidates for surgical valve replacement. TAVI is conceived for patients who are not optimal candidates for surgical valve replacement. Now in 2020 or now 22, surgical aortic valve replacement is indicated. That means surgery is indicated in patients who are not optimal candidates for TAVI. It's reverse. Earlier TAVI only for non-surgical cases. Now surgery is only when you can't do TAVI. So this is what has reversed, a new paradigm, reverse of the indications now. So this is an old slide, more than 5 lakhs procedures have been done in 65 countries and lot of this. I would like to tell you that other than Sapien 3, which is Edward Life Sciences, which had taken a PVT where Dr. Kleber was working, Evolute R, which is from Medtronic, is a self-expanding device, which is a different system of working. And superiority has been proven. This is how it is done. Retroflex device. This is technical details. I will show you a little later. So TAVI, a valid alternative to valve replacement in high-risk patient. TAVI, the treatment of choice in inoperable patients. Marked and long-lasting quality of life improvement. 2 valves were developed at the same time. France 2 registry, Belgium, UK registry. I want to highlight that so many registries. When you develop a new technology, you have to have so many techniques. Alain Alchanina, along with Alain Cribier, the France registries was done by published, and that was long time 2011 before the partner trial. And this is Martin Gillard, who was the French Society of Cardiology, president of International Cardiology Society, president. They had the first registry which was published. The New England Journal of Medicine, everybody knows, is a highly reputed journal of cardiology or rather medicine. It not only publishes the cardiology journal, cardiology topics, but also covers the medical topics. So it is to get any publication done in the New England Journal of Medicine is in itself is a big work done. So now I would like to highlight one last 10 minutes. I would like to tell you about the case report. The procedure in 2011, almost 11 years back, 28th November, we had to do a case which was done actually in Rouen, but the patient belonged to Delhi NCR, and he approached me because this patient knew from somewhere that I am known to Dr. Alain Cribier. I worked with him, and in 2011 this technique was not available in our country because DCGI had not yet approved it. Partner 3 trial results and 1 and 2 results were already oncoming. 83-year-old Indian male was treated with transcatheter aortic valve implantation for severe symptomatic aortic stenosis in Rouen, France. Patient presented with recent onset symptom of angina, exertional fatigue and dyspnea. He had a severe aortic calcific stenosis, valve area of 0.7 cm square, P gradient of 85, mean gradient of 65, ejection fraction maintained, and hypokinesia. He was already a bypass surgery patient. He already had an earlier bypass surgery 14 years back. He had a long-standing diabetes mellitus. His graft patency status was evaluated by angiography done by me, and they revealed the left internal memory artery and the saphenous vein graft to RCA was normal, although the graft to obtuse marginal was occluded at the origin. He had a poor lung function and he had nephropathy, that means kidney failure and the lung failure. That is why this patient was actually refused by the surgery in India. Surgical consultation led to conclusion that high-risk surgical valve replacement. It was decided to treat the patient with TAVI. Pre-procedure evaluation in India included MRI of the heart and the whole of aorta, common and external iliac and femoral artery, which confirmed that the aortic annulus of 23 mm, and CT angio was not confirmed because it was a bad kidney functions. The patient was treated successfully by TAVI in Rouen by Edward XT valve. 18 French sheath was used. Novaflex Edward XT valve, conscious sedation with IV midazolam, ProStar technique for femoral artery closure, and procedure time was only 45 minutes. I was there along with Dr. Alan Crebier working with there. You can see this is how the video clip shows the patient was being, this is some video clips which is show the initial portion from the groin. This is how the groin is being prepared, and then this is a pigtail catheter. We check with the coronary to find out how much is the aortic leak, and then this is how the valve is going. This is not the valve. We are picking the place for the valve to go. This is a sheath, 18 French long sheath in place, Novaflex sheath. There's a lot of technical things, but it does not take more than 45 minutes in expert place. 18 French Novaflex sheath in place, descending aortic angiogram was done. You see, then after that, Amplat's catheter for crossing the aortic valve. The valve is crossed, the Amplat's catheter. Pigtail in the aortic root, aortic valve is crossed. Now pigtail is kept here, and now they say we are already through the aortic valve. Balloon aortic dilatation is being prior to deployment of valve. You see the balloon aortic valve plus, you see the balloon going up. I'll show you this again and again. This is, you can see how the balloon is going. Balloon is going up, that means being inflated. It is making the place for the valve to go, like what we do in the stenting. Novaflex sheath with Edward XT valve being positioned. This is how the valve is going up. And with the X being positioned. Novaflex sheath, Edward XT valve is being positioned. This is how the valve is going up. Edward XT valve being positioned. Number 3, this is how the valve is going up from the groin into the heart. This is the valve, how it is crossing. These are very important pictures, video pictures. This is the valve, how it is going up. It takes about few seconds, not maybe around 1 minute to put the valve, because it's a huge structure, and now you're crossing from the groin. I will show you from this. That means it is coming from the opposite side. It is coming from down below, from the groin. Wahan se the valve is going up, and now this is the valve which is being put non-surgically. Now the valve is exactly at the place where it needs to be deployed. This is a very important step because you have to be at the right place. You cannot miss the place. You cannot be up and down, and you have to keep checking with the help of dye being put from the pigtail catheter. This is again aortic root angiogram to see the exact position, because you cannot miss it. You cannot, if you put it down, it will lead to problems. Now this is how the valve is going up. This is very important. This is the final how the valve is being positioned and then being deployed. I'll show you again. With the help of balloon, the valve is being positioned and deployed at the site of the previous valve in a patient who is conscious, in a patient where you have not opened the chest, in the patient who is being done percutaneously from the groin, and a patient whose heart is beating. This is in a beating heart. You can't put a valve surgically in a beating heart. You have to go on the pump. So putting the valve in a beating heart is actually a very important thing, and I always salute my friend Dr. Alan Crebier my mentor and friend both, who did develop this technology. So immediately after this, pressure aortic gradient was reduced to peak from 18 to 10. Aortic root angiography revealed mild aortic regurgitation. This is what you see. Only mild, which improves immediately later on. And the patient, this is the final step. You take out the balloon and then you take out the sheath. And now after taking out the sheath, you check angiogram. Everything's fine. After removing of the groin sheath, with the help of ProStar technique, which is the non-surgical technique, and this is how the valve look on the fluoroscopy. And the patient, the creatinine level had mild elevation, it normalized, and patient was discharged within 3 days. And as I tell you, this patient lived till 2019 when we lost him because of some other kidney failures, other problems. He was already 84, so we lost him something like 90 plus age. So this patient, minimalist environment with conscious sedation, procedure time of 45 minutes, and perhaps this was the first Indian patient to receive the TAVI technique, from India, first Indian, but of course we had to do it in France. As of now, more than 5 lakhs patients have been done, and there are two strategies in America, maximalist versus minimalist environment. This is something which I want to discuss. Local anesthesia and conscious sedation, which France is doing, most of the European countries are doing. At least Dr. Krieber technique is there, that don't give general anesthesia, while in most of the patients in America, they are using the general anesthesia and they are taking it to maximalist to minimal environment. This is the patient, a team of 6 in the cath lab. This is the French place. Conscious sedation, local anesthesia, no transesophageal echo, per closing with ProStar. 10 French, this is the ProStar 10 French, duration procedure 45 minutes, discharge on day 1 to day 2. While in America, if you see the same thing, more than 20 patients, people inside the lab. This is Emory Hospital in Atlanta, USA, and of course, you don't do it. Current indications, I told you that all the patients with clinically risky patients or even the less risky patients should be done. We have to do a heart valve team, a decision of TAVI, cardiac surgeon. We always involve the cardiac surgeon and then interventional cardiologist. Do it with the nurses, technicians, geneticians, and echocardiographists. Anesthesiologists have to be standby. Severe vascular disease, stroke, paravalvular AR, all these things are very less. And therefore, now we are moving ahead in the patient's paradigm where even the less risky patients are being treated with this new and novel technology. There are some new approaches which can be done. Transfemoral is done in 80%. Some people have tried transapical, subclavian artery, carotid. Finally, you have to get the valve from here. It goes from here to here and then to the valve. So this is how the technique goes. You have to put the valve here. That most people are doing from here. That means from the groin. You have to cross this area. But few people have done direct aortic. Then few people have tried transapical, direct by the surgery. And few people have tried from subclavian or axillary artery. But the most commonly used is from the groin and the safest technique. And the Sapien 3 valves are being used, 20 size, 23, 26 and 29 millimeter size. At the same time, core valve, which is coming up and being used by Medtronic. This is by Edward. The difference is this is self-expanding, while this is balloon expandable and this is self-expandable. So Sapien 3 trials, so a lot of trials, I'm not going to tell you details. This is already a lot of what are expanding the indications. Improvement of device and strategies to make TAVI safer, faster, simpler and cost effective. Almost achieved. Trials in specific subset of patient, low risk patient, it is also being achieved. Valve and valve, it's getting achieved. It's now achieved. We're pending about 3 years back, now achieved. Assessment of valve platform durability of long term, 5 years, more than 9 years in Rouen. That means durability. The patient life, the valve lasts for at least more than 10 years, which has been seen. In my case, 7 years. But patient died because something else. Device, procedural cost, reimbursement, regulatory issues are on the way. So general conclusion, this is last slide of mine to present it to you. This is how the hierarchy goes. 1985, balloon valvuloplasty. 1994, postmodern studies on intravalvular stenting. 1999, PVT formed because of search of the sponsor. Animal implantation in sheep. 2002, first in-man implantation. 2002 to 3, feasibility studies. 2004, Edward Life Sciences transfemoral and transapical. 5 and 7, international transfemoral and apical feasibility studies. 2007 CE mark commercialization. And then 2007 again post-market CE mark means in the Europe it is now commercially available. What FDA does and what DCGI does in India, what FDA does in the UK, Europe, sorry, in America, in US, in France, in Europe it is CE mark. And then partner B trial, then FDI approval happened in 2012, and this was because America is a maximum user of this technology. FDA approval happened in 2012 in high risk patients, and now partner 3 trial has shown that it can be used in the low risk patients. And in March 2014, FDA approval in high risk patients with the core valve, which is another technology, and a long clinical pathway, 25 years from balloon aortic valvoplasty, 18 years from concept, 10 years from FIM. This has been a 10-year was made, nearly 6,000 attendees, March 13, 2012. Actually, it was a celebration, and which I must be sitting somewhere here in this photograph. I also attended this program. This was 9 years post TAVI, normal valve function, healthy function, a medical breakthrough which has been done with the obsession or something like that, which has saved the life and improved the quality of life of thousands of patients or lakhs of patients who otherwise would have been left untreated and died. So this is actually a life-saving technology improved and given by Dr. Alan Crevier. Within 10 years, might become the predominant therapy for calcific aortic valve stenosis. So 2022, with technological advancement, the number of centers and procedures should continue to expand in high surgical patients. FDA approval, TAVI is being used widely. Expansion of indication to other subsets of patients such as less severely ill. Expansion of indication to other subsets less severely ill. Younger patients can be expected. Control registries are requested. Less invasive process stent-like must be used. Nobody knows, probably used in vast majority of patients with severe aortic stenosis. So there is no negative comments, just a wink. So negative comment from there is finished. And I would like to show you or share with you some important pictures with what I had shared with Professor Alan Crevier during my stay in Rouen in France. So give me a minute. I would like to show you some pictures of myself with Dr. Crevier. If I have one, some videos are there, but I don't know the video will play during this time or not. Can the video be shared or not?
Yes, doctor, you can share your screen. Just on the bottom, when you share a video, just click on the option which says share with audio.
Okay. Let me see. I'll like to show you. But can I share the one of the YouTube? Can I open a YouTube and share it on this platform?
Sir, as far as there will be no copyright issues, you can share.
No, it's my own video. My own video.
Yeah, you can do that.
Let me try this. Just a minute. Yeah. Only one video I would like to share with Dr. Crevier. He was a very important person. So I have to go to the video set. Where should I go?
Doctor, you can share your screen and then open the YouTube link on it. There'll be an option when you click on share screen, which will give you an option to directly share the YouTube tab.
Just click on the screen where you are there.
Okay. I share the screen and then YouTube optimize with YouTube. Share sound. No.
Yeah, you have to click on share sound so that the sound will also be shared.
Which one? I have to open the.
Just click here.
Share. I have to share the YouTube link.
Click the share. Yeah, and now open. May I use now? Now, do you need to play this video?
This is a recording of. Are you able to see this? Are you able to see this?
Visible. Yes, doctor.
You can see the video.
Yeah, we can see the video as well as the audio is perfect.
Oh, good. This is how. This is a very important thing because I was working in 1997. One video for Aortic Riviere. I'll show you. This is Aortic Riviere working in France. The normal radiography. It's not a very good recording because at that time. Video cassette. 1997. Aortic Riviere is the style in the cath lab 1 of Charles Leclerc. We already done the puncture. Now we are doing the coronary angiography procedure. This is the cardiac catheterization lab of Charles Leclerc Hospital, and it's the same place where the first case of TAVI was done. Same cath lab, but this is 1997. I'll just cut it short and show another video. It's a rare thing to have worked with Alan Trippier, father of TAVI. I always remember, relish, nostalgic about this time when I was just 29-year-old or even less. This is technical area. The report of the dictaphone. This is a very good system of making the report. And then this is where the reporting system is done very carefully. They do recording on the dictaphone. And the dictaphone is listened, they see, and then they type the whole report. This was system in 1997. So I will now show you another one. We do not have the system in our. Let me close this. अब दूसरा एक और दिखाना है. कैसे करेंगे? इसको बंद करना पड़ेगा. हाँ, इसको बंद कर. है?
जो भी आपको दिखाना है.
Another one. Okay. Give me a minute. I want to show a very important video when he came to my house because it's a memorable day for me to discuss on TAVI with him. Somehow that video is not इसी में सर्च करेंगे कैसे होगा. Yeah, this one. So many videos. I'll show you two more videos. Interesting. Okay, so scroll कर दे. कैसे शेयर करना?
You just click on the same video.
हैं?
Just click on the video you want to play.
हाँ.
Yeah.
Then.
Just ask
Hello?
is the video.
हेलो. हाँ जी, मुझे ना डेंगू हो गया, मैं बेड रेस्ट.
So, my friend, I said that I'm so happy that I'm receiving my mentor, guru, godfather, and what else? My friend, my house at Sarita Vihar, New Delhi.
Can you see the slide video?
So many years. Wish
Yes, doctor.
he can come to my
So
house.
this is a very rare phenomena or rare event or rare day Alan Clifford sitting with myself at my residence.
With a dealer. Not just
A very celebrity doctor. So I've used the slide just to show you that how close we are together.
No, we drink, we have been drinking alcohol, so we are really crazy. At the moment, yeah. Well, no, it's a great moment. We enjoy the dinner and the atmosphere and the football and everything. And it's the first time that I come to your house.
Yes,
So, I'm so happy. Well, it's not the last time. I can tell you. When you come next in February, you'll find one good evening. Why don't you come with us?
Yeah.
So, like chin man, gentleman. My wife together with our, I want to clarify something. He is your son.
The sense of humor.
Don't forget his name. And one thing more actually, recently released the 1.5 years or whatever time we spent through us. I still have very fond memories. This is my colleague, Carl.
Okay, so these are two important videos which I wanted to share with you, and I hope you liked it. So any questions are there, or should we?
I'm Dr. Vivek Gupta, professor in Apollo Hospital, New Delhi on 24th of February.
Just a minute.
It's also my birthday. Talking about
Answer them. And this was indeed a very insightful webinar, and I'm very happy that you conducted this webinar with us. And we hope you'll be conducting more such webinars in the future. Thank you so much for your time. Have a great day.
Thank you so much. Just a minute. Yeah, okay. But can you?
There, the small video.
Yeah, doctor, is there something before I end the live session?
Yeah, just a minute. So I think just to summarize for people, aortic valve replacement is indicated in many patients who are elderly. This is changing the valve with the open heart surgery. But now this technique is going up, and we are able to change the scenario, saving a lot of lives. The patients who are partially inoperable, for example, something like more than 70, 75 years age, of course are candidates for TAVI. But now even the less operable patients, less risky patients, the patient who can be operated, but they want to choose this non-surgical technique, should be the same way treated by TAVI, transcatheter aortic valve implantation. And I'm thankful to you for your giving us the opportunity to talk about it, especially the librarian, and your personally coming up and joining us in the session. And I hope that people will like this YouTube webinar, and people will be able to see again and again and talk and discuss with me. If any queries, I will be happy to answer with them. Thank you very much.
Sure, doctor. Thank you so much. Okay, so doctor, you're no longer live. You have any